Okay, welcome everyone. Thank you for joining us today. I'm going to let the participants online trickle in just for a couple more moments before we begin, but I just wanted to introduce my name is Ethel Rojas. I am the Senior Manager for the research theme in Health Equity and Translational Social Science. I want to thank UCLA, CTSI for having us nominate these wonderful speakers today. Okay, I'm gonna just go with it. And so I wanted to introduce with great pleasure, Drs. Cynthia Davis and Dr. Alexander Rodgers, who are from the Charles R. Drew University of Medicine and Science. I will first introduce Dr. Davis. Dr. Davis, she teaches in the Urban MPH program at Charles R. Drew University. From 1981 to 1983, she served as a research assistant with the National Hospice Study and was recruited to work at Charles R. Drew University of Medicine and Science in 1984, directing one of the first California state teen pregnancy prevention programs targeting at-risk racial, ethnic, minority youth residing in South Los Angeles County. In 1986, she was recruited to direct the federally CDC-funded National HIV/AIDS Information and Education Project, a national HIV/AIDS education and primary prevention project targeting elected and appointed African-American officials throughout the US. She directed this national program from 1986 to 19. She then developed the first dedicated HIV mobile testing and community outreach project in Los Angeles County in 1991, and she served as co-investigator from 2001 to 2006 on the HRSA-funded National SPNS project. She joined the board of directors of AIDS Health Care Foundation in 1988, formerly the AIDS Hospice Foundation, which is the largest nonprofit AIDS service organization in the world, serving over 1.6 million clients globally. She is actively engaged in community service and research projects for the university, and in 2017, the Cynthia Davis Lifelong Learning Institute for Community Transformation was named in her honor by the College of Science and Health at Charles R. Drew University of Medicine and Science. Our other guest speaker, Dr. Alexander Rodgers, is the Associate Program Director for CDU's Family Medicine Residency Program and Medical Director of the university's Mobile Health Outreach Program. In 2014, Dr. Rodgers received his medical degree from the David Geffen School of Medicine at UCLA and completed his family medicine residency at Kaiser Permanente Fontana Medical Center. With a strong interest in health policy and health equity, he also completed an MPH and fellowship in minority health policy through the Commonwealth Fund Mondian Fellowship in Minority Health Policy at Harvard University. His current professional interests include mobile health service delivery, leadership development, optimizing healthcare delivery to individuals experiencing homelessness, and understanding the relationship, community development, and one's health. Thank you so much, and welcome, Dr. Davis and Dr. Rodgers.
Good afternoon. Good afternoon. I want to thank you for this invitation. My name is Cynthia Davis, Assistant Professor, and Dr. Rodgers and I are going to talk today about our model street medicine program. The title of our presentations is Lessons Learned from Serving Through Two Pandemics. So disclosures, we have no financial disclosures or conflicts of interest to disclose. And we have several learning objectives. Number one, to provide a history of CDU's involvement with mobile street outreach in medically underserved communities. to describe partnerships established with public and or private sector organizations to enhance service provision, to describe current statistics on COVID-19's impact on medically under-resourced communities of color, and to highlight lessons learned and best practices. So in 1985, CDU received funding from the LA County Department of Public Health to initiate one of the first HIV/AIDS primary prevention programs in South LA, targeting school-age youth and young adults. We collaborated with Martin Luther King Hospital and the National Organization of Black County Officials to develop and implement a CDC-funded National Information and Education Primary Prevention Project, targeting Black elected and appointed officials on a national scale from 1985 through 1992. During this time, we also implemented 2 CDC-funded grants from 85 to 92 on a local and national level to combat the spread of HIV and AIDS in the African-American community. So what were some of the challenges with this first pandemic that we addressed? In the late 70s, HIV and AIDS was severely impacting at-risk populations of gay men, injection drug users, hemophiliacs, and women of childbearing age in the US. Racial ethnic minority populations were being disproportionately affected by the HIV/AIDS pandemic, and minorities and women were not being adequately included in early HIV/AIDS clinical trials. Also, conspiracy theories that HIV was a man-made virus and a form of global genocide against Black people were very prevalent in the African-American community in the United States. And there was no effective HIV/AIDS treatments in the early 90s. However, there was an emphasis by local health departments and the CDC on getting at-risk populations educated about their risk for acquiring HIV, as well as being tested to know one's status. So under my leadership through the Department of Family Medicine, we were able to develop and implement the first HIV dedicated mobile health outreach project, which we call MOHOP in LA County in 1991, with funding from the Magic Johnson Foundation, Burroughs Wellcome Pharmaceutical Company, and the LA County Department of Public Health. LA County Department of Public Health replicated this model mobile outreach project and funded 6 additional CBOs in LA County beginning in 1992 to implement HIV mobile testing programs throughout LA County. Also during this time period, we collaborated with the Gay and Lesbian Adolescent Social Service Center, or GLASS, and Children of the Night to target runaway and homeless youth living on the streets in Hollywood, as well as we targeted at-risk youth living in some housing developments in South LA. And this project was implemented from 1992 through 1996. So free primary healthcare services were provided on this MOHOP van, as well as HIV antibody screening services. Staffing included a family medicine physician, a physician assistant, a medical assistant, 3 HIV testers and counselors, and several community outreach workers. Medical residents from the Department of Family Medicine also rotated through the MOHOP project as part of their residency training in adolescent health and community health. The outcomes of this program: we served over 5,000 youth. These were unduplicated visits, and we documented an HIV seroprevalence rate of 10% among the youth seeking HIV screening services from 1992 through 1996. And then over the course of 10 years, we utilized 2 mobile vans targeting substance misusers and other at-risk populations throughout LA County for HIV primary prevention, and have screened for HIV over 60,000 LA County residents during the period 1991 to the present. So we also have been engaged in community-based participatory research. One of the key programs that I'm very privileged to talk about is our partnership with the UCLA Department of Family Medicine, where I work with faculty member Billy Cunningham and Dr. Mitch Wong on a 5-year special projects of national significance program funded by HRSA It was a research project utilizing our mobile van to target medically underserved HIV positive racial ethnic minorities who had fallen out of care. And on this project, we were able to develop an enhanced case management model, which facilitated HIV positive clients being linked back into care. It was implemented from 2001 through 2006, and the outcomes that we were able to serve a little over 200 clients. And post-intervention, we were able to document that fewer clients were utilizing the emergency room for primary care visits. There was also an increase in HIV positive client CD4 counts over an 18-month period. So now we're going to segue into what we've been doing, utilizing this model of mobile outreach during the COVID-19 epidemic, and Dr. Rodgers is going to present on this. Thank you.
Thank you, Cynthia.
Mhm.
Yeah, so just to transition over to COVID-19, I want to discuss some of the challenges that we were facing as a community in South Los Angeles and really as a nation. In South LA, we noted extremely high case rate. That combined with higher rates of chronic comorbidities and accessibility issues to acute healthcare services, definitely posed a risk and concern for our high morbidity and mortality from COVID-19. When the pandemic initially hit, thinking about what you can controlling what you can control, testing was really our only real active measure of prevention, aside from masking and social distancing and closing down of unnecessary programs. But once the COVID-19 vaccination was rolled out, we had other tools and resources available. But still, there's concerns about accessibility within South LA. And then the other factor is just the change in sentiment over the period of 2020 in desirability to receive vaccination. And South LA was no different. So during the months of January 2021, the COVID-19 pandemic presented an unprecedented strain on public health and healthcare resources worldwide. South LA was no different, right? There was a tremendous surge. I practice at MLK Outpatient Center. That's the county side, which is the primary care clinic. MLK Community Hospital, which is a private hospital, had an extreme surge of patients. And I remember walking in every day, seeing, 10 to 20 ambulances lined up outside the ER waiting with their patients inside the ambulance waiting to get a bed, so that way they could be triaged. And certainly, the feeling of this equity within South LA was palpable. And I can show 3 slides, two graphs and a map that kind of highlight the feeling that the general gestalt that the community was feeling, right? So this is some preliminary data for another research project that I'm working on. But these are the case rates during the 2020, 2021 winter surge of COVID-19 cases per 100K population, and they're color-coded by service planning area. And that brown line at the top is service planning area 6, where SPA 6, where South LA resides, and MLK and CDU. At the same time, as far as access to adult inpatient beds per 100K population, this brown line at the bottom is SPA 6 again, right? Pretty much we have St. Francis, right? We have MLK Community Hospital, and a couple others, but not the high resource for acute care services in South LA. Another way to represent this is in this map. This is a historical map from 2019 showing where all the hospitals are placed around South LA. The blue dots are hospitals that are currently still established, and then the red dots are where hospitals were but have since been closed. And so, given that combination of challenges that I pointed out, it's it's a little surprised that the rate of COVID-19 deaths during the 2020 winter surge and 2021 winter surge hit South LA particularly hard. You see in the Watts, Compton, and Willowbrook area, pretty much the CDU catchment area, rates were as high as 315 per 100K population compared to Westwood, where we were at 55. And this data is from the LA COVID dashboard, if you want to reference it. But then, the vaccine came out and we had a chance for real action and hope to turn the tides on the pandemic. And LA County established 6 vaccine super centers, which I have highlighted in blue here. So this is Six Flags, that is Cal State Northridge. Down in spot 4 is Dodger Stadium, the Forum. What is this one down here? In East LA, I can't remember. And then the Fairplex in Pomona. Okay. And I showed this map again for reference later in the presentation, but this orange dot is where Kedron healthcare is. And then the orange square is where CDU is. Just to point out that we are, the 2 institutions were both geographically and philosophically in a position where we could provide a unique service to South LA and SPAL 6. Going back to vaccine hesitancy that I alluded to on the previous slide, obviously discussion around and sentiment of vaccine uptake was a big challenge. You see that there's this article from JAMA kind of highlighting that across the board, there was a decline in likelihood of getting the vaccine from April 2020 to December 2020. But I'll draw your attention to Black and Hispanic individuals, which are make up the predominant demographics in SPAL 6, where Black individuals were asked in December 2020, 37.6% said that they were likely to get the vaccine. 52.7% of Hispanic surveyed said that they were likely to get the vaccine. So vaccine hesitancy over the course of the year, it increased sharply, right? As they had a lot of questions and doubt and misinformation spread. So controlling what we can and letting the score take care of itself. CDU wanted to focus on accessibility to COVID-19 testing, vaccination, and vaccine uptake sentiment, right? And I promise I'll get back to MOHOP first, but I wanted to try and put it in context of what all of CDU has done in response to the COVID-19 pandemic. And you see the woman on the right here is Dr. Sheila Young, one of the CDU faculty. Pre-vaccine distribution pretty much turned our front parking lot into a mass testing site. And with her student volunteers going door to door, letting people know that there's free testing available at CDU, and through the partnership with the Department of Public Health, she was able to test over 27,000 Angelenos. And I remember our residents, our role was to call back those who tested positive and make sure that they were plugged in with services and they were aware of their positive test results. I also want to show one more major player, which is Jerry Abraham, again on the right here. Jerry Abraham is another faculty at CDU. He is director of vaccines over at Kedron, and again transformed the front yard of Kedron into a massive, essentially unofficial vaccine supercenter. I think that there is at its peak, they were vaccinating over, I think, 10,000, 8,000 to 10,000 individuals a day. And, I mean, he was just working tirelessly. So getting back to the mobile health outreach program, it was established in January 2020 with the primary goal of serving uninsured individuals, particularly individuals experiencing homelessness. As the pandemic reached the West Coast, we went back and talked with our grant sponsor, CVS Foundation, and said, hey, there's a really big need in South LA. We need to broaden our scope to provide COVID-19 related services to all inhabitants of South LA. And of course, they agreed. And so we broadened our scope to provide COVID-19 testing and vaccination services to all underserved individuals throughout LA County. And this was, again, in support with Jerry Abraham and the team over at Kedron Health as our primary vaccine distributor. So our model with the CDU Kedron Mobile Health Outreach Program is we go where people live, work, worship, play, and go to school. And certainly it's around engaging community, engaging community-based organizations, faith-based organizations, employers, and saying, hey, we're here to support you and all the people that you serve. And how can we help out? And creating these community-based vaccination events, right? By February of 2021, we partnershiped with over 2 or 3 dozen individuals. This is just a list of some of the organizations that we worked with. And the thing that we did to try and make sure that we were really reaching areas that had issues with access and uptake was we would use GIS data to highlight regions in LA County where vaccination rates were exceptionally low. This picture is one of the events that we set up over at Gonzalez Park, which is in Compton. And that census tract area had an exceptionally low vaccine rate. So we wanted to make sure that we frequented that area, many times, just to make sure that we were providing vaccine access in that region. We also saw that Service Planning Area 1, which is kind of Victorville, Apple Valley area, had very low vaccine uptake as well. And so we started doing trips up there, partnering with a network of faith-based organizations. So our team is comprised of 2 physicians. We usually have one of our family medicine residents on board, our case manager. We have 5 nurses that the Department of Public Health has contracted to us through emergency use authorization. We have 1 EMT who's our head of vaccinations, 1 health educator, HIV tester and counselor, outreach worker, and 2 van drivers who drive our 35-foot mobile testing clinic and our 2 Ford cargo vans. The services that we provide the whole spectrum of COVID-19 vaccines, Pfizer, Moderna, J&J, and the bivalent boosters. And that's intentional because when it comes to harm reduction and meeting people where they are, they may say, well, I'm willing to get Pfizer, but I will not get Moderna. Or I just want to get J&J and be done with it, or some combination of those And having all three vaccines at every event has certainly increased our ability to get more people comfortable with the idea of getting vaccinated. With the rise of the monkeypox epidemic, we also started doing monkeypox vaccinations and therapeutics. We also do hypertension screening for diabetes and hyperlipidemia, screening for HIV, condom dissemination, health education, COVID-19 test distribution, and opioid education, Narcan spray, and fentanyl distribution. Over the last about 2 years now, we've done over 400 mobile health deployments. We've vaccinated over 18,000 Angelenos. We have done over 500 health screenings. We've vaccinated over 300 high-risk individuals against monkeypox, and formed collaborative partnerships within the public and private sector, around 75 organizations. When it comes to addressing vaccination hesitancy, this is again another university-wide effort. Cynthia and I, along with many other faculty in the university, would have a lot of frequent virtual town hall meetings with community-based organizations and faith-based organizations. We would do door-to-door outreach and have health fairs. This picture here is actually with Reverend Thornhill, who's the pastor of the Minority AIDS Project. Thank you. This was one of the events where he literally, threw a party around us, setting up vaccines in his community. And, that really kind of speaks to the collaboration that we have with our faith-based and community-based organizations. Okay. And again, we also partnered with Jamil Lacey, who is the head of TRAP medicine. He's a med student here at UCLA, actually. And his focus is around barbershop health, right? So you see, this is one of our residents of the residency program getting a haircut while we were at a vaccine event, and really just making that connection, right? Going beyond just providing services and rendering service, but having that one-on-one interaction with people. So I'm gonna hand the mic back over to Cynthia so she can discuss some of the best practices.
So based upon this model and over a 30-year history of being engaged in community outreach, community-based participatory research, I wanted to list some of the best practices that I've identified being out in the field in that length of time. So having ongoing collaboration with community-based providers, including substance abuse, social service, WIC, churches, parks, social clubs, high schools, post-secondary institutions, parole, probation departments is key by developing relationships and building trust with these organizations. Also returning to sites weekly or monthly with our mobile street outreach team and partners to gain trust among community residents and to build up credibility. Again, use of GIS mapping to implement block by block targeted outreach in areas of high morbidity for COVID-19 and low vaccine uptake. And then also making available incentives for people to get vaccinated, such as in this case, we made available $25 Target gift cards for the first 25 to 50 people who came to our mobile outreach site to get vaccinated. We coordinated a significant number of outreach activities at high volume venues in the community, such as the annual Taste of Soul Street Festival, which I just think they just celebrated their 17th year, and we've been at all 17 of those street festivals where you have upwards of 350,000 people in attendance, and also at the annual KGLH Women's Health Forum, which started out at a church in South LA over 21 years ago, They asked us to bring our mobile van there to do HIV testing. We developed this partnership, and that event has grown to where over 8,000 women attend this event on an annual basis, and it's held at the Long Beach Convention Center. We, again, try to coordinate our outreach activities with well-respected and trusted CBOs and faith-based organizations. And just for a few, our First AME Church, Crenshaw Christian Center, Community Coalition, and again, KGLH radio station, which is owned by Stevie Wonder. We also use social media to promote outreach activities, and we've developed a project newsletter where we promote all of our activities. And then we established early on in the pandemic a public-private sector COVID-19 task force that met weekly to address the unmet needs of under-resourced communities, primarily in SPA 6. We also conduct vaccine outreach activities in the evenings and on the weekends because, again, our motto is we meet people where they live, work, pray, and go to school and congregate. And we have been able to incorporate community-based participatory research as well as clinical trials into the university's overall vaccine community mobilization initiative. And we've hired and trained individuals from the community to work with the program to give it more credibility.
So just a few global lessons, more philosophical. You know, public health interventions are at their core human-to-human endeavors. And when it comes to, you know, something as far-reaching and as dire as, you know, a fatal pandemic, right? Making that connection and just trying to simplify the work that you're doing, even though you're reaching, you know, tens of thousands, you want to focus on that one person in front of you. When it comes to access, it goes beyond just physical proximity. Is being emotionally accessible, is being ready to hear what they have to say, and you know, using that motivational interviewing techniques that you've learned to try and meet them where they are. As Cynthia pointed out, community participation is critical for high buy-in and turnout. It's, you know, I would say that part of the success of the current program is the trust in the community that Cynthia has built up over the past decades, right? So reliability and consistency is key in any community-based program. And so we play the long game, right? You know, we understand that we may not get a win every time, but we know that consistently we will be on an uptrend to improving health in South LA. And I'll stop right there. This is our contact information. Thank you.
Thank you.
They're to open it up for questions.
I think so.
So I know that most of us are online. Yes. We're going to monitor for online questions.
Thank you so much, Dr. Davis and Dr. Rodgers. I was wondering, what are your future plans, and do you have any plans to possibly scale up, and anything that we can do here in the Westwood area to try and help the South LA?
You want to answer that, or?
Yeah, you go first.
Well, we definitely want to scale up. One of the key things that we're going to be doing, or we're working on doing, is integrating in the street medicine program into the family medicine residency training program, as well as with the new medical school starting next summer, that we would hope also medical students would be able to come out as student learners to gain experience under a preceptor in terms of how to adequately and be culturally competent in terms of addressing the needs of underserved and under-resourced populations. We are working with faculty from UCLA to establish a social medicine clinic in South LA, working with the street medicine program. We've already identified a site. We've had meetings in the last year. They've had a couple of listening sessions with providers as well as at-risk youth from the community. And so we're well ahead in that process in terms of developing MOUs and determining when we'll actually start those services in South LA. So that's very, very exciting. So those are the two key things that I'm, going to be focusing on in the next year to make sure that that happens.
Okay, so thank you so much for that presentation. And this is Helena Hansen. I admit that I have a big interest in this collaboration with UCLA around a social medicine collab and mobile clinic with you, and wondered if you could comment, because most of us are likely from UCLA. A lot of us have logged on online virtually. I don't think we really took into account all of the events, local events, including the strike that's happening right outside when we planned this. But for the audience online that's mostly UCLA, I wonder if you could comment on what's a productive way that UCLA can partner with you. What might be some contributions that we could make given, what you know of who we are, our resources, that would complement what you already do. I say that knowing that you already have quite a comprehensive approach to street medicine and a lot of support at Drew. And I'm just wondering, for those of us at UCLA, what might we bring? I think it's clear how we could gain, but are there things that we could bring to it? And what's the best approach for us in collaborating with you?
Yeah, absolutely. That's a great question. So, I feel, I'm happy to see that UCLA and CDU have such, robust history with each other and collaboration, not just in medical education, but also in research and clinical services. As Cynthia pointed out, I think that one of the goals of the street medicine program going forward is to try and pivot back to our initial goal of providing primary care services. And we've done that to some extent with the addition of health screenings, but we want to try and really push it out to be as robust as, as if we were a brick and mortar facility, right? But on wheels. And I was talking with Dr. Brown earlier, and she had mentioned that one of the faculty out here is actually leading a mobile CT scanner. And, I just thought that was fascinating. So, I mean, you guys are really doing some truly innovative work here. And I think that there's a lot of opportunity to meet. I think the challenge is trying to get everybody in the same room so we can have these discussions and conversations. So, thank you for bringing us here to have this conversation and to share our work, because I'm sure that more will come from it.
Thank you.
Thank you so much, Dr. Davis and Dr. Rodgers. I am desperately in need of possibly your help with what I've been working on. I've worked with
Pull your mask down. It's hard to understand
I'm
you.
so sorry. I was just commenting on, it's been a pleasure to work with you and try to organize my end of the street medicine outreach by gathering up a group of young adults, transitional age youth. And sometimes it's like trying to round in cats. They can be in so many different areas of their own personal life. What I would like to find out is, do you have like a teen meeting monthly, a young adult meeting monthly that I can direct my young people towards sitting in on?
We currently do not have a monthly meeting where we're bringing together young adults from the community. In the past, I used to do that. And again, I've been doing this almost 40-something years. We used to have a peer advocate training program and we had a CAB and the youth were involved in that, but I haven't done that for years. But that's not to say it couldn't be done. I mean, we have a high school on our campus, the King Drew Medical Magnet High School, where young people from that high school could be recruited to be part of a CAB. We have the youth that you guys have already targeted in some of your listening sessions. And again, if we're once we finalize this partnership with Chucos or the Youth Justice Center, that would be a prime site
I think.
to bring together a group of youth from that site in terms of a CAB to provide ongoing input in an advisory capacity. Then I work with other organizations like the Bridge Builders Foundation, which has been around for 20-25 years, and they provide scholarships to racial ethnic minority youth. And then they have a STEAM program. They work in several high schools in South LA. They do ongoing programming and intervention with high school age youth. So that could be another group that we could also approach to get young people involved.
Thank you so much for your answer. I appreciate it.
We have a question online from Lucia Williams. One of the things is to get community involved like Drew has done. We have community faculty on the advisory board and Dr. Rodgers is one of my mentees. So shout out.
Thank you, Ms. Plus, for logging in. I really appreciate the support. And certainly we definitely rely heavily on our clinic community faculty to make sure that we're going in the right direction, right? Ms. Plus is oftentimes my reality check to make sure that we're doing things that are worthwhile and wanted within the community. So yeah, thank you, Ms. Plus, and Dr. Booker Vaughn and all the other community faculty at CDM.
Well, thank you so much. I really appreciate for your time. Unless do you have anything else, Dr. Hanson? Sorry.
So this is kind of a follow-up question to ways that UCLA-based students, trainees, faculty could work productively with you. I know we've had questions about research, about how to document, analyze the work that you've already been doing, the work that you plan to be doing. And I wonder if you have some thoughts about the kinds of data or analysis that would be useful moving forward for promoting this model, for improving this model. What would be the role of research and what type of research?
That's a really good question. And, I sit in on a couple meetings where, mobile outreach programs countywide, we come in and we try and get on the same page about what we're doing for mobile health services in LA County. And I think the question is always around value proposition. How do we make a case for the values? Certainly we see the impact in the health of the individuals that we serve. But how do we make a value proposition so that way is integrated into brick and mortar, clinical institutions, and it's deemed, fiscally sustainable and worthwhile, right? So, there's some literature that talks about, looking at dollars saved, right, for services rendered through mobile health services. There's some studies that have tried to quantify the amount of ER visits that were avoided through mobile health services, but nothing really robust to try and put a pin on what is the true value proposition of mobile services. And that would be something really interesting. And I think that there's not just in CDU, but kind of countywide interest in trying to research and understand that more.
And you think ER visits that were avoided, complex complications, things like that?
That was one of the areas that Dr. Cunningham was investigating when we did that special project of national significance back in the early 2000s. One of the things was to evaluate our Mohawk program to see for the positive clients that we identified. We didn't have a case manager on the van at the time to see when we made the referral for treatment, did people actually get into care? And because people at that time were testing confidentially, we had information where we could go back and call up individuals who had sought out services on our van and determine whether or not they actually got into care, were linked into care on their own. And surprisingly, of the several hundred people that we were able to make contact with, over 80% of the positives that we identified did get into care, which was a very positive thing. And then with the assessment that we gave the people that we had identified who had fallen out of care, again, we were looking at ER visits where there was a reduction in ER visits, and there were, then we were looking at clinical outcomes. CD4 counts went up once those people were being case managed. And what was the third thing? I can't think of the third thing, but we do know that you can look for clinical outcomes as well. And so we know the model works. We've been doing it for 30-something years. I think a lot of people don't even know that the mobile outreach program that the medical students started over 20-something years ago was based upon our Mohawk program.
The UCLA?
Yes, it was. There were UCLA, CDU students who knew when we were closing down our program, who met with me to get information on how they could continue the program. And once we closed down due to lack of funding, they continued the program just a couple of blocks where we had been for 5 years. And we even at the time would go out with that team. I think they were going out Monday evenings between 5 and 9 or 5 and 10. They had a preceptor, and they eventually had brought a provider on who actually made hot food available. So the homeless people would come and line up on ramparts, get their hot meal, and then come around the corner and go to the van and get all their medical services. It was amazing what those students were able to do. And that program is still going on, but it was based upon our model. Yes.
Thank you.
Mm-hmm.
Well, thank you so much. Thank you for coming and attending here.
Thank you.
Thank you.
Thank you.